Hi, hello. I'm Constantino Pena, an interventional radiologist at the Miami Cardiac and Vascular Institute. I'd like to discuss with you today the Flex Vessel Prep System and really results from the acute complex vessel anatomy study. These are my faculty disclosures. When we speak about vessel preparation, we're really speaking about the concept of modulating a vessel in order to allow dilatation to its final diameter, to then allow for the best definitive therapy. It may modify plaque, it may improve vessel compliance, and hopefully reduces dissection and risk of other complications. Hopefully it may also improve the fusion of DCB therapy, all in all to have safe dilatation and treatment and improve outcomes in our patients. The Flex Vessel Prep system allows for controlled plaque modification in all different types of morphologies and asymmetric lesions. It allows for consistent, long micro-incisions that then may prepare the vessel for subsequent treatment, such as DCB therapy, and hopefully will enhance future drug access. It's safe with a predictable controlled depth at micro-incision and should minimize risk of dissection, perforation, and other complications. It's very easy to use due to a simple design with a simple pullback, and really requires no vessel sizing. And it is cost efficient as there's no capital equipment, just simply the catheter. So when you take a look at what the Flex system device looks like, you see that as a device with a handle. On the handle, there's really only two buttons. One is the treatment element actuator, and the second is the sheath actuator, which will then open up the treatment element. As what we see here is that there's an atraumatic tip. You advance it over an 014 or 018 guide wire, and then you pull back the sheath actuator to expose the treatment element. The treatment element will have three small precision blades that will then oppose to the wall of the vessel. In a simple pullback technique, you'll then pull these treatment elements across the vessel, creating the micro-incisions. Here you can see a description, a picture of what I just kind of described. You can see there opening up the sheath, and you can see the treatment system there opening up. And as you pull back, you see the treatment element opposing to the wall and creating these micro-incisions. Typically, after you do one pullback, you may then close this device, advance it back in the vessel, turn it slightly, and have 2 or 3 different pullbacks. What do we see when we do this type of technology? You see these small micro-incisions. So this is real-world plaque morphology. You can see how irregular it may be and asymmetric in multiple areas, but you can see consistently through these slices these small micro-incisions. Additionally, when you look at this type of treatment after a DCB therapy, you see the deposition of the DCB and of the drug along these micro-incisions. We really tried to look to see what are the results of this device so far. So we did a multi-center retrospective review of about 185 real-world cases. And by real world, we're looking at long lesions, usually greater than 20 centimeters, and 69% of them had moderate or severe calcium. All lesions had at least some element of a CTO that measured at least 8 centimeters. These lesions were then all prepped with this type of flex vessel prep device, and then treated with angioplasty or a DCB. When you look at the baseline demographics, you see these are 185 patients, 60% were men, with a mean vessel diameter of 5 millimeters. The lesion length, again, average of 20.8 millimeters, but ranging from 10 to 41 centimeters. We saw a vessel calcification, again, 69% with moderate or severe. What's interesting, when you look at these results, you saw that the luminal gain after the Flex device was 34%. That's without a balloon. When you went ahead and had a balloon, you only needed an average of 4 atmospheres for effacement. There were no significant dissections, with only 3% type A dissections and 1% type B dissection. In this retrospective review, there was no evidence of embolization, perforation, or flow-limiting dissection. And provisional stenting was only needed in approximately 28% of this 185 real-world cases. So the key results so far from these review of this studies of these patients, we see that post-Flex, we see 34% luminal gain prior to treatment. When they had inflation, they had subnominal inflation pressures of only about 4 atmospheres, with a very low rate of dissection, and most of these were type A and B. There were no flow-limiting dissections, perforations, and embolizations, and provisional stenting was only needed in 28% of the cases. Let's go look at some case studies. Here we see patient one of the case studies, a 71-year-old male with Rutherford class 5 symptoms. Patient was treated with 3 passes of the Flex device. You can see in the pre-procedure image the occlusion. After passing the Flex device 3 times, you can see what the vessel lumen looked like. And then after treatment with angioplasty and then DCB, you see a complete dilatation and a very good result. And you can still see the calcification there being pushed to the side. Again, luminal gain after Flex was 70%, and there was no post-procedure stenosis. Patient number 2, a 72-year-old female with Rutherford class 3 symptoms. This patient had an occluded SFA, and you can see in the middle picture after passing the Flex device 4 times, you can see that a lumen has been created. This was estimated at approximately 50%. After treatment with angioplasty and then DCB, patient has a post-procedure stenosis of 10%, and this was seen in that image on the far right. So in conclusion, the FEX system effectively modifies real-world plaque, including CTOs, in the SFA popliteal arteries. Most importantly, it appears to be safe and limits the risk of potential dissection and perforation and embolization. It then also allowed for subnominal inflation with good vessel compliance and dilatation. Now, further studies will be warranted and will be performed to help confirm the reduction of these long-term reintervention rates. Thank you very much.